Good day to everyone watching us, and I am very pleased and very happy to be joined to discuss the data that came out of our recent ESMO meeting by three eminent colleagues in the field of GU malignancies and specifically prostate cancer. We have gender equity today and we have discipline equity today. So I am joined by Dr. Elena Castro. Elena is a renowned medical oncologist who has had an international career, as you know, but is now focused on being back to her country in Spain. And also by two very famous urologists from Germany, Dr. Merseburger. Alex is known also for his work in the field. And of course, Nicolas Mottet, who is one of those figures that has always been my nemesis in the field, haunting me for having always have to have very accurate data. So he always keeps us in check. And that is why, Nicolas, I left you last, but definitely not least. So we had some great data regarding hormone-sensitive prostate cancer, or as I like to call it, hormone-naive prostate cancer, that are potentially practice changing. And I want to get the feel from my European colleagues with the understanding that I also practice in both US and Europe on how this will shift our practice. But we also are going to put this data in perspective by bringing up what is real world practice. And finally, we will turn to the future to see what are the efforts with regard to molecular characterization of the disease. So we should kick this off with a closure we got from the Arches trial. We had heard the first data from Arches a while back. I will turn to Axel first and ask Axel to, if you can, summarize the trial for us and give us your thoughts on the data that was presented and whether indeed they provide closure or not and how they can change what we currently do.
Well, Eleni, first of all, thanks a lot for including me in this expert round and to discuss on those most recent developments on MHSPC. So this advanced metastatic prostate cancer, we have three hormone combination options, namely abiraterone with prednisone, apalutamide and enzalutamide approved in most European countries. And approval of enzalutamide was based on this Arches trial, a large phase 3 trial, randomized double-blind placebo-controlled study of enzalutamide plus androgen deprivation therapy in men with metastatic hormone-sensitive prostate cancer. And so far, only the PFS was positive, and we're waiting for the overall survival results. And here, last week at virtual ESMO or hybrid ESMO meeting, we saw the Arches final analysis, the overall survival analysis showing a statistically and I think also a clinically meaningful hazard ratio of 0.66 benefit for the combination ENZA and ADT compared to placebo ADT. With regards to number of events, it was 154 events in the combination arm compared to 202. And I think it's always important to just hear those numbers because those are the men behind those trials. So really showing a very, I think, good result for our men with advanced prostate cancer. Now we have Titan data for apalutamide, latitude data for abiraterone. But I think here with apalutamide and enzalutamide, we really can use the substance in a very broad patient population, the so-called all-comer population, showing really a good safety profile, nothing new. And I think this is pretty fair that we have those data now also for enzalutamide. Thank you.
Thank you very much for that. I think I want a comment from Elena regarding Arches trial. You know, Elena, we as was pointed out, we knew it was a positive study. We all had the fear that it was not going to show us overall survival, but it did do that. For me, it points to the value of earlier is better, and I will loop back to that. And that is where I'd like your comment. There were a lot of patients in control that were crossed over. Do you have the same sense? Does it reinforce the need to start earlier with enhanced androgen signaling inhibition is my question.
Yes, I totally agree. And I think that we have now several trials that have demonstrated that the earlier we start therapy in patients with metastatic prostate cancer, that results in a clear benefit for our patients. And that should become our standard. And we should change our practice in those cases in which that if we are still using ADT and monotherapy for these patients.
Just to add on, if I allowed, on the data, we had 31% of patients crossed over to open label ENSA. So I think this again underlines the use and what you just said, Elena, that therapy intensification upfront really makes sense, and at the end you never catch up.
That is a great point. You never catch up. And Nicolas, do you have now any doubt in your mind? I mean, we have 5 positive trials. I know we're waiting for more data from Enzamet. 5 positive trials. We're waiting for one more. Arison's ongoing regarding the importance of adding on early on an androgen signaling inhibitor.
No, I do believe the evidence is there. We shouldn't spend time to discuss that. We should spend time on how to make this happen in real life for every patient. That's something different. If I want, I will be the bad guy again, as usual, regarding this trial. Arches was positive. What a surprise! We knew it would be positive, and so once again, it highlights the fact that the androgen receptor is really a key driver in prostate, no question. And if I want to remember the old physicians, that finally Fernand Labrie was correct. Combination therapy is definitely the way to go.
Thank you for that comment. And thank you for not being the bad guy for once. You were not at all. I mean, to the contrary, I think you softened up a little bit. But with that in mind, now you're going to be the one taking on the chemotherapy question, right? I mean, the big bang, one of the 2 big bangs during this ESMO was PEACE-1 reporting. Quite a convoluted design. Who else than a Frenchman to describe us exactly what is going on there? So to you.
Well, the PEACE-1, the trial itself, the design of the trial, it was initially standard ADT, standard of care. Initially, standard of care was ADT. Abbey, dose was allowed, but it was not mandatory. Later on, it was suggested it had to be in, so the standard of care changed. And finally, docetaxel was mandatory. So we have issues with patients that did not receive, some of them received, and finally all of them received docetaxel. You all know the trial that it wanted to show that a triplet is better than a doublet. That is ADT plus dose plus Abbey versus ADT plus dose. And it also wanted to show if adding radiotherapy in both groups add anything. Karim only showed results regarding with or without Abbey. Clear, positive results. For me, what it means, first, that using ADT plus docetaxel should no longer take place. Docetaxel monotherapy on top of ADT is definitely out. It reinforced the fact that targeting the androgen receptor as much as possible is really the way to go. What it did not answer, and I must insist on that, that was not the objective of the trial, is there still a place for dose? And during the ESMO, there was a discussion for the highest risk, not for the highest risk. All this is purely interpretation. I'm not aware of a single trial clearly showing that dose adds anything on top of Abbey. This trial, for me, reinforced the fact that the strongest androgen deprivation therapy is clearly the way to go. It doesn't prove for me that adding dose on top of that improves anything. It improves toxicity. There is no over toxicity. The toxicity is not a surprise, but do we finally improve the outcome? Let me remind everyone, Abbey is positive, whatever the initial extent of disease, high risk, low risk, high volume, low volume. Most of the included patients with the Abbey trial were asymptomatic. And we know that the dose, usually it's the preferred option when patients are highly symptomatic. But the mass majority of patients we see are not so highly symptomatic. The second key message from this trial is that, and Karen pointed that very clearly, most patients that relapse were treated with Abbey later on. And once again, it shows that the earlier, the better. So for me, these are the two main points with this. Dose monotherapy on top of ADT, clearly out. And second, earlier is better. What it doesn't show is that a triplet is better than a doublet using Abbey. And for me, this remains the burning most important question.
Nicolas, I have to say we're going in different directions. I am putting water in my wine as I grow older. You're becoming bolder and bolder. So with that in mind, I love it. I love your comment. I will turn to Elena and try to get, for now, kind of her thoughts regarding docetaxel. You're saying something quite strong. I'm not ready to say it because I want to pick my fights and I want the proof that docetaxel is out. So Elena, in your mind, I understand where you're coming from, totally. And I will get Elena's thoughts on that and Axel's thoughts on that, given urology, medical oncology.
Yeah, no, I agree that the PEACE-1 has definitely demonstrated the role of abiraterone for this patient. No doubt about that. And I'm also questioning whether docetaxel has anything to add to this. And I'm still thinking, well, maybe patients with very high volume disease in which you really want to do as much as possible and try intensify therapy all we can in one go. But still, I agree that maybe we need another study to answer that question and to really get that data. On the other hand, if we do not intensify therapy at that time and patients receive abiraterone for a number of years, we still may have chemotherapy to be used when these patients progress. So my question is whether the sequence of therapies is still better than the intensified therapy up front. And I don't know if anyone has that answer.
Yeah, I love that point. And it just dawned upon me. Docetaxel was put in question by Jetuk, and it's again put in question by the French. So Axel, please, what are your thoughts? I mean, should we do what Elena is saying? Do we need a trial that's going to address it as a sequence event?
Mm-hmm. Well, I think it's an easy task. I could only echo my friend and neighbor Nicolas here at the border. So I think he was exactly right, and I think Karim could answer this question if he would look at the subgroup out of PEACE-1 who received Abbey and ADT in the times when it was still standard of care. So we have the data. It would be a subgroup, but this might be of interest to have a look at this in PEACE-1. Otherwise, PEACE-1 changed my mind with regards to when I give chemo, and those would be the high volume or high risk young men or recommend chemo. Then I would really have to think if not to combine with Abbey upfront. I think this is justified when you look at PEACE-1 data, PFS 2.5 years, more than 1 year overall survival benefit. So I think this is an easy winner. However, most of the patients, as also already alluded by Nicolas, have not that high risk, high volume disease. And I think here my preferred first line option would be hormone upper, or the just discussed enzalutamide. This would be my take home and what I do the next Monday after ESMO. But it's really, really tough and a lot of new data. And again, another aspect we haven't touched on, the approval status of the substances. Abiraterone here is not so easy that in all countries it's approved in combination with docetaxel and ADT.
Thank you, Axel, for that. I'm concerned. I can't yet say that I will bring docetaxel out in high volume disease. I will have the discussion with the patient. I really loved Elena's question about the sequencing. We haven't really proved that up early on of docetaxel is the one that makes the huge difference. I would totally agree. We need a little bit more data, but for now, I think, and I keep saying that, we need to be focused on monitoring these patients if we're going to offer everything. Yeah. With that in mind, Axel, I will come to you again as a urologist now, because I want your take and description of the STAMPEDE data that, again, as always, STAMPEDE is changing the way we're practicing medicine through a real live study that's community-based, and it's close to our everyday practice. And I want to speak first to you because it has to do with this high-risk localized disease that they address, and get your thoughts on the study, and then, of course, turn to Elena and how it will change her practice.
Well, thanks. So yes, this is a real-world treatment pattern in metastatic hormone-sensitive prostate cancer, and you probably picked me because it came from my friend. We just met hybrid at ESMO in Berlin while we were discussing the data, Peter Goebel, and he had this real-world treatment survey: US, Germany, France, China, and Japan, and so we see what we discussed: a change in treatment, therapy intensification, but definitely we are not there where we want to be, and definitely we are not there what we discussed just in this call here, that we are in the future and discuss about triplet therapy. So we would be happy, and this was also the take-home message of this real-world scenario, to get the treatment intensification up front and not just single ADT. And there was another poster at the ESMO and showing the same, that still about 60% of men with MHSPC just receive ADT. And I think this is not standard of care in 2021 anymore. Happy to hear your thoughts.
No, I will. I totally agree. It was very devastating to see the poster show that less than 20% of men are exposed to an enhanced androgen signaling inhibitor, even in countries where it is readily available. But with that in mind, the world is moving forward, and that's why I wanted to, while the practice is staying behind, the STAMPEDE trial, that's not a rigid trial, went on to address the locally advanced disease setting. Elena, can you give us your thoughts on the STAMPEDE report from ESMO?
Well, the STAMPEDE study has been reporting on the metastatic of patients with metastatic disease, and at ESMO this year they reported for the first time data on patients with high risk localized disease. And very briefly, what the investigators observed was that for patients with high risk prostate cancer who were treated with conventional radiotherapy, the addition of 2 years of abiraterone resulted in improved metastasis-free survival and improved overall survival as well. There were also some patients in this study that received, on top of the abiraterone, also received enzalutamide. And this intensive therapy, the results did not differ from abiraterone in monotherapy, but was followed by more side effects. So there could be two conclusions. One is that the addition of abiraterone here results in improvement and improved outcomes for these patients, but not for adding too many therapies will result in a more significant difference, right? So I think now this should become a new standard for these patients with high risk. And this also reinforces what we have been discussing, that in these patients with high risk disease, either because it's localized high risk or metastatic, the earlier therapy with androgen receptor inhibitors is beneficial for these patients.
Nicolas, from your standpoint, as a person involved in the guidelines, the data coming from STAMPEDE this time, is it convincing for practice change? From your first interpretation, I know you need to see the manuscript and the granular data.
Okay, let's say the manuscripts say the same thing. We need to realize two things. First of all, a STAMPEDE is not a randomized controlled trial in this case. It's a formal comparison of two experimental runs at the same time, as was shown with Dose and between Dose and Abbey by Mercedes. So it cannot be level 1 evidence, but at least the survival benefit is so huge that even if it might become a weak recommendation, I think the evidence is there. I must insist, it cannot be in guidelines as long as it's not fully published. And I guess it will be fully published by the end of the year. I hope so. We'll have to check that. So it will be in the next one, but based on a comparison of two experimental arms, it cannot be a level 1 evidence, purely methodologically, purely based on a methodological definition. It's clearly positive, no question. It makes sense, no question, but that's it. I have a comment regarding STAMPEDE. It's not high risk. It's very high risk. It's not the high risk as we define it. The Gleason score, the PSA value were the highest. And the interest of that is, let's open an absolute nightmare Pandora box. It's M0 based on bone scan and CT scan. And suddenly we know that if we jump to PSMA, this absolute nightmare and extraordinary change, very often they will in fact be M1. So once again, if the trial is positive on conventional imaging for M0, added value of these new imaging modalities might be highly questionable in terms of improvement if the benefit is already there with the old-fashioned imaging. That's a Pandora box I close now because it's a different topic.
No, this is a very big discussion, and I actually find it reinforcing, and I know we're limited for time, the fact that we saw reporting survival data within 6 years of median follow-up. That means we're looking at a very, very high risk localized disease, enriched for what you're saying, oligometastases and per PSMA positivity. But that gives us the opportunity to actually separate and say, what is conventional M0 may very well be metastatic, and we should not exclude these men from getting the potential maximal treatment. With that in mind, Axel, I need a very quick comment. STAMPEDE is not able to address anything regarding radical prostatectomies and the like, has never been designed to do that. What we're living in areas where radical prostatectomy is part of high-risk localized disease. How can you incorporate for now that paradigm with what STAMPEDE say?
Well, I think I would look in the guidelines. We just have the chairman of the guidelines sitting here with us. So, and there the updated version 2021 says in high risk, PSMA imaging is recommended. And this is what I would want to have, and also what I recommend my patients. So really in high risk, and as Nicolas just said, a super high risk, I would want to have a PSMA PET because it's more sensitive, it's a one-stop shop imaging and less radiation to it. And then we would start again, that's somehow back to the future at the beginning of our discussion, because in a large percentage of cases, we will have MHSPC disease, and then we come with arches tighten again. So I think to end up my short comment, I think modern way is to include patients in trials like the Proteus trial with the apalutamide before, a neoadjuvant before radical prostatectomy. Those trials and several more will probably shed more light on this discussion, what's best for our patients. Otherwise, STAMPEDE, this will probably not be practice changing for us in a PSMA-friendly country.
Great. Again, a discussion we can continue. Elena, we saw just a couple of abstracts trying to molecularly characterize the disease in hormone sensitive. And you know my opinion is I think that the future is going to be there, and we are going to find a paradigm eventually similar to what breast cancer is doing. Any comments from what you saw regarding characterization by PTEN status or temporis erg and what it could mean in the future?
Yes, there were a couple of small series, but I think they are very interesting. With regards to PTEN, what the investigators observed was that the prevalence of PTEN loss was similar than the one that has been reported in castration-resistant disease, which is probably because PTEN loss is an early event. And they have observed that also in this scenario, the PTEN loss is associated with poor outcomes. So the next thing is try to see whether AKT inhibitors probably have anything to add in this scenario, particularly if we are going to use abiraterone more and more in this hormone-sensitive setting. The other abstract you mentioned is regarding whether expression of TMPRSS2 ERG can be associated or not with outcomes and with the response with therapy. And the results are still very preliminary, but it seems that it suggests that, yes, it could be also another marker of response to therapies in this setting. We need to see, and I guess, as you were saying, since the field is moving to the hormone-sensitive status, metastatic hormone-sensitive disease, we will need to learn more and more about biomarkers and whether the ones that we have investigated in NCRPC are still relevant for this scenario, the hormone sensitive, or whether we may have into account other new biomarkers.
Excellent comment. Thank you all for joining us. And I hope that these questions that were more than the answers we got are going to be answered eventually. Great day. Thank you.
Thanks a lot.
Thank you.